Hello, today we have lecture day number 6. The topics are vasculitis, Wegener's granulomatosis, Goodpasture syndrome, and idiopathic pulmonary hemosiderosis. Granulomatosis with polyangiitis, Wegener granulomatosis. Granulomatosis with polyangiitis is characterized by necrotizing granulomatous inflammation, small and medium-sized vessel vasculitis, and focal necrotizing glomerulonephritis, often with crescent formation. It affects both sexes equally. Most commonly affecting whites, but can occur in all ethnic groups and at any age. Mean age at onset is 40. The cause of GPA is unknown, although immunologic mechanisms play a role. Most patients with active generalized disease have anti-neutrophil cytoplasmic antibodies, ANCA, against proteinase 3. Characteristically, granulomas form with histiocytic epithelioid cells and often with giant cells. Plasma cells, lymphocytes, neutrophils, and eosinophils are present. Inflammation affects tissue as well as vessels. Micronecrosis, usually with neutrophils, microabscess, occurs early, progressing to macronecrosis. Onset of GPA may be insidious or acute. First, insidious, the full spectrum of the disease may take years to evolve. For example, patients present initially with upper and lower respiratory symptoms with kidneys being affected later. And acute, onset of systemic manifestations is relatively acute. Several organs and systems are affected simultaneously. Upper, lower respiratory tract, peripheral nervous system, and kidneys. Typically, the upper and lower respiratory tract and kidneys are involved, but any organ may be. GPA should be suspected in patients with chronic unexplained respiratory symptoms and signs, particularly in manifestations in all other organ systems, especially the kidneys. Also should suggest the disorder. Routine laboratory tests are done, but ANCA testing and biopsy are most conclusive. Routine laboratory tests include erythrocyte sedimentation rate and C-reactive protein, marks of active disease. Complete blood count with differential serum albumin and total protein and serum creatinine. Urinalysis and 24-hour urine protein, expressing kidney function. Chest CT without contrast is nearly always necessary because chest X-ray may miss nodules, masses, and/or cavitary lesions. Most patients with active disease have cytoplasmic ANCA, c-ANCA, with antibodies against proteinase 3 because tests for rare diseases are likely to be false positive when ordered for the general population, and the positive predictive value, PPV, of a positive ANCA test is around 50%. ANCA testing should be reserved for patients in whom the pretest probability for GPA is at least moderately high. For example, patients with alveolar hemorrhage, glomerulonephritis, or multiply mononeuropathy, plus other features of GPA. Positive ANCA test does not rule out mycobacterial and fungal infections. Thus, patients with positive ANCA results and cavitary lung lesions still require bronchoscopy and other tests for TB, tuberculosis, and fungal infections. Biopsy should be done if possible to confirm the diagnosis. Biopsy of affected lung tissue is most likely to reveal characteristic findings. Renal biopsy that shows pouchy immune necrotizing focal crescentic glomerulonephritis strongly supports the diagnosis. Treatment of GPA depends on the severity of disease. For less severe disease, corticosteroids and methotrexate are used to induce remission. Cyclophosphamide rituximab may be used instead of methotrexate. For upper respiratory tract manifestations, rituximab appears to maintain remission better than cyclophosphamide, methotrexate, or azathioprine. Patients who have severe life-threatening or organ-threatening manifestations, for example, alveolar hemorrhage, RPGN, multiply mononeuropathy, require immediate hospital admission for treatment and induction of remission. These patients require high-dose corticosteroids and cyclophosphamide rituximab. Corticosteroids are tapered to as low a dose as possible or discontinued. Goodpasture syndrome is a subtype of pulmonary renal syndrome. It's an autoimmune disorder that most often manifests as diffuse alveolar hemorrhage and glomerulonephritis together, but can occasionally cause glomerulonephritis, 10 to 20%, or pulmonary disease, 10% alone. Men are affected more than women and with bimodal age distribution, 20 to 13 and 60 to 70 years. Goodpasture is caused by anti-GBM antibodies directed against the non-collagenous domain of alpha-3 chain of type 4 collagen, which occurs in highest concentration in the basement membranes of renal and pulmonary capillaries. Environmental exposures, cigarette smoking, most commonly viral respiratory infection and hydrocarbon solvent inhalation, less commonly expose alveolar capillary antigens to circulating antibody in genetically susceptible people, most notably those with HLA DRV15, DR4 and DRB1 alleles. Circulating anti-GBM antibodies bind to basement membranes, fix complement and trigger a cell-mediated inflammatory response. Hemoptysis is the most prominent symptom. However, hemoptysis may not occur in patients with alveolar hemorrhage, and patients may present with only chest X-ray infiltrates or with infiltrates and respiratory distress, respiratory failure, or both. Up to 14% of patients have gross hematuria, although pulmonary hemorrhage may precede renal manifestations by weeks to a year. Signs vary over time and range from clear lungs on auscultation to crackles and bronchi. Some patients have peripheral edema due to renal failure and pallor due to anemia. Patients are tested for serum anti-GBM antibodies by indirect immunofluorescence testing, or ELISA. Presence of these antibodies confirms the diagnosis. If anti-GBM antibodies are absent and patients have evidence of glomerulonephritis, for example, hematuria, proteinuria, red cell CAS, etc., renal biopsy is indicated to confirm the diagnosis. Immunofluorescence staining of renal or lung tissue classically shows linear immunoglobulin G deposition along glomerular or alveolar capillaries. Treatment is daily or every other day plasma exchange for 2-3 weeks to remove anti-GBM antibodies, combined with corticosteroids, usually methylprednisolone intravenous infusion, followed by prednisone orally and cyclophosphamide to prevent formation of new antibodies. Idiopathic pulmonary hemosiderosis is a rare disease that causes recurrent diffuse alveolar hemorrhage with no detectable underlying disorder. Occurs mainly in children 10 years. The disease is thought to be due to a defect in the alveolar capillary endothelium, possibly due to autoimmune injury. Many patients have celiac disease. Symptoms of idiopathic pulmonary hemosiderosis in children include recurrent episodes of dyspnea and cough, particularly non-productive cough initially. Hemoptysis occurs later. Children may present with only failure to thrive and iron deficiency anemia. The most common symptoms in adults are exertional dyspnea and fatigue. Diagnosis of idiopathic pulmonary hemosiderosis involves demonstration of a combination of characteristic clinical findings: iron deficiency, anemia, and hemosiderin-laden macrophages in bronchoalveolar lavage fluid, plus no evidence of small vessel vasculitis confirmed by biopsy, and other findings are inconclusive. Treatment is corticosteroids may reduce the morbidity and mortality of acute episodes of alveolar bleeding and may control the disease progression of pulmonary fibrosis. Some patients may require additional immunosuppressive drugs. This is the last slide, and thank you for your attention.